Okay, so today we are going to be talking about obstructed labor. So this is for the definition. Obstructed labor can be defined as a labor where there is a poor or no progress of labor in spite of good uterine contraction, or as one where in spite of good contraction, the progressive descent of the presenting part is arrested due to mechanical obstruction. Then this may result either due to factors in the fetus or in the birth canal or in both. So that the further progress is almost impossible without assistance. Then incidence. So in the developing countries, the prevalence is about 1 to 2% in the referral hospitals. Then causes. So we have maternal conditions, fault in the passage. So we have cephalopelvic disproportion, contracted pelvis, abnormal pelvis, could be an android or anthropoid. Then pelvic tumors such as fibroids in lower uterine segment, e.g. cervical or broad ligament fibroid, ovarian tumors, ovarian cysts impacted in pouch of Douglas, or tumor of the rectum such as bladder or pelvic bone. Then abnormalities in the uterus and vagina such as cervical stenosis or vaginal stenosis, contraction ring in uterus, vaginal septum or rigid perineum. Those are some of the maternal conditions where there is fault in the passage. Then fetal conditions, so fault in the passenger. So you can have macrosomic baby, malpresentation such as broad presentation and breech. Then you have compound presentation, malposition such as transverse eye, occipital-posterior position, mental position. Then congenital malformation of the fetus, such as hydrocephalus, which is the commonest. Then you have fetal ascites, conjoined twins, cord around the neck, locked twins. So that's some of the causes. Now to morbid anatomical changes. So the uterus, what happens in the uterus is that there is a gradual increase in the intensity of the duration and frequency of uterine contractions. The relaxation phase becomes less and less. Ultimately, a state of tonic clonic contraction develops. Then the retraction, however, continues. Then the lower segment elongates and becomes progressively thinner to accommodate the fetus, which is driven from the upper segment. So of course there is a figure which you are going to see. Then a circular groove, a circle in the uterus is formed between the active upper segment and the distended lower segment, called the pathological retraction ring or Band's ring. Then due to the pronounced retraction, there is fetal jeopardy or even death. So what we are talking about here? So this is what we meant. This is the normal pathogenesis of the retraction ring or Band's ring. So this is normal labor, that's how it is. But on part B, there is a late obstruction. You have to note the circumferential dilating and progressive stretching of the lower segment, which corresponds to the upper segments, which will lead to the rise in the level of retraction following obstruction. So that's the baby will be pushed, and this ring will be formed. So that's what it means. Okay, so in prime gravida, a further retraction ceases in response to obstruction, and labor comes at a standstill, which is a state of uterine exhaustion. Then contractions may recommence after a brief period of rest with renewed vigor, but in mort para, retraction continues with a progressive circumferential dilatation and thinning of the lower segment. So there is a progressive rise of the Band's ring in multiparous women, so moving nearer and nearer to the umbilicus, and ultimately the lower segment is going to rupture. Okay, this is a Band's ring. That's how it looks like. Then this is, as you can see, This is the Banzering ear. Okay, so this is the normal shape of the abdomen. Then if there is a retracted upper segment, then the Banzering, then the distended lower uterine segment. Then if this continues, the lower segment is going to rupture. Okay, then morbid anatomical changes. So we were talking about the uterus, now the bladder. So how does the bladder change? So the bladder becomes an abdominal organ, and due to compression of urethra between the presenting part and the symphysis pubis, the patient may fail to empty the bladder, and the transverse depression at the junction of the superior border of the bladder, and the distended lower segment is often confused with the Bann's ring. So the bladder also gets traumatized, which may lead to blood-stained urine, which is a common findings in obstructed labor. Then the base of the bladder and urethra, which are nipped in between the presenting part and the symphysis pubis, may undergo pressure necrosis. Then the devitalized tissue becomes infected, and later on uh, slough off, resulting in the development of genitourinary fistulas. So some of them you already know which are VVF, which can actually occur due to this same compression. Okay, then diagnosis. So pathograph will recognize impending obstruction early. If the labor is slow to progress, careful general abdominal and vaginal examination is necessary. Then woman gives history of prolonged labor, and the labor pain becomes severe and frequent, and bearing down. Okay, that's the history. Then examination. General examination, there will be features of maternal distress such as exhaustion, which is due to a constant agonizing pain and anxiety or anxious. Then there will be a painful state, tachycardia or feeble pulse, dehydration, which is due to increased muscular activity without adequate fluid intake. Then there will be raised temperature. Then there will be scant concentrated urine containing ketone bodies or blood, or sometimes metabolic acidosis is due to accumulation of lactic acid and ketones. That's where the metabolic acidosis comes. Then pre-abdominal examination find on inspection there should be tonically contracted uterus, then distended urinary bladder, full bladder in short. Then there will be a Bann's ring, which is the retraction ring. Then on palpation, the uterus is going to be tender. Then the liquor is going to be odorant. Then the fetal parts will be difficult to palpate. Then the fetal ultrasound shows evidence of the fetal distress or even absent, difficult to auscultate or abnormalities in the fetal outlet. Okay. Then on vaginal examination, the vulva is usually swollen and edematous. The vagina is dry, hot, and occasionally offensive and purulent. Then the cervix is almost fully dilated or hanging like a curtain. Then the presenting part is extremely molded and jammed in the pelvis. There is usually large caput formation, then meconium draining, of course. Then the uterus, if the uterus has ruptured, the fetal parts will be palpable in the peritoneal cavity, and uterus is felt as a separate firm mass. Then some of the complications of obstructed labor. So what are some of the complications of obstructed labor? So we have maternal ones such as uterine rupture, PPH, VVF like we talked of, RVF, puerperosepsis, shock, annular detachment of cervix, maternal death. Then fetal complications, we can have intrauterine fetal asphyxia, which is resulting from the tonic uterine contraction that interferes with the uteroplacental secretion, or due to cord prolapse, especially in shoulder presentation. And then intracranial hemorrhage, which is due to molding of the head leading to tentorial tear or due to traumatic delivery. Then neonatal infections such as pneumonia due to ascending infection. acidosis due to hypoxia and maternal acidosis. Then of course fetal death can occur. The management, how do you manage obstructed labor? So preventive measures can do a proper assessment of the pregnant woman during antenatal care. Then regular antenatal care visits, focused is usually recommended. Then proper assessment in early labor to detect the cause, if any. Then pathographs have to be strictly followed. Then prompt follow appropriate treatment to solve the problems. That's the preventive measures. Then curative measures, we have A, which is the immediate management, so what you are going to do there and then. So we also have gender and obstetric management, which is before proceeding for definitive operative treatment. A rupture of the uterus must be excluded. Then a balanced decision should be taken about the best method of relieving the obstruction with least others to the mother. Then frantic attempts to deliver a moribund baby by a method ignoring the risk involved to the mother is indeed bad obstetrics, and there is no place of wait and watch, neither any scope of using oxytocin to stimulate uterine contractions. Okay, then immediate management. So of course, immediate management, two radical cannulas have to be inserted. Then you have to administer fluid to correct maternal dehydration. Then blood sample have to be sent for HB grouping and X match, and also bedside clotting time. The contraction prevention by tocolytic drugs. Then ultrasound to confirm fetal viability. Then those are the immediate. Then general, you can do a quick assessment of height of mother and general condition, IV fluid to correct dehydration, broad spectrum antibiotics, triple therapy, where you can use triple therapy cover, or use ceftriaxone 1 gram IV and metronidazole IV. Then the other is catheterization, sodium bicarbonate infusion to correct acidosis. Then C, the obstetric management, which is for your definitive now, whether you're going to deliver the fetus by vaginal delivery, or destructive options if it's a dead fetus. Then if the head is low and vaginal delivery is not risky, forceps extraction may be done in a live fetus, which is of course is contraindicated or indicated in some. The use of forceps should be individualized, or ventors should be individualized, not in all patients. If the head is low and vaginal delivery is not risky, you have to individualize the indications of these instrumental deliveries. Then cesarean section, if it's a live fetus, or if it's a over distended lower segment with impending rupture, even when the fetus is dead. So that's an indication. Then active management of the third stage of labor, of course. Then continuous bladder drainage for 2 to 3 days to prevent VVF. Okay, then that's the obstetric management and definitive. Then that's all. Thank you for watching, and check out other videos as well.